So you've been here for about 3 years. We were so happy to recruit you from Pittsburgh. What brought you here, and what's made you excited about Stanford?
Well, I mean, aside from the weather, that was a big change. But the thing that brought me here was that a good opportunity for building on sort of a great program. So, as you know, Stanford did the first adult heart transplant a little over 50 years ago, and they have sort of a long track record of great heart failure and transplant and now VAD experience. And so one of the kind of major things that had grown up here was that transplant here was a little bit different because it started here. So transplant grew up a little bit separately from everything else because there wasn't really a heart failure, especially when transplant started here. And so transplant and heart failure, and to some extent mechanical circulatory support, were together but not linked under a section per se. And so I came here as sort of the first section chief, kind of linking and grouping all of those facets together. So it's been a lot of fun doing that, and sort of thinking about the inpatient services and how we reorganize those with everything under kind of one rubric in the clinic. And I think that the other exciting thing about coming here was, like I said, the wealth of experience and research for both transplant and mechanical circulatory support, and working with the general cardiology group in terms of building up the heart failure research as well.
The landscape of heart failure has been changing. As you say, mechanical circulatory support came on with bounds, and then, the guidelines for transplant have changed. What do you see as the next, the paradigm shifting things that are coming up in heart failure over the next few years?
Yeah, I mean, I think in heart failures, the paradigm shifting things, I think, are one, for whatever reason, we keep discovering medical therapies that work for systolic heart failure, which is great. It seems like it's hard to believe with all the evidence-based therapies that new therapies can come online, but that's been the case with the SGLT2 inhibitors. So I think that medical therapy is getting better. Unfortunately, on the diastolic end, things haven't gotten a whole lot better, although hopefully we'll move forward. I think technology is going to be more and more part of the heart failure regimen in terms of patient monitoring, both invasively and non-invasively. I think on the transplant side, as you mentioned, the allocation system changed a couple of years ago now, and that impact has been felt mostly in the world of mechanical circulatory support. Mm-hmm. And, about half of the patients in the U.S., roughly had been on mechanical circulatory support prior to transplant, prior to the recent changes in the UNOS allocation system. But with that, there's been a dramatic decrease because patients have been able to be transplanted prior to needing mechanical circulatory support with the new system. Mm-hmm. We've seen that here at Stanford, maybe a little bit more impactfully than we've seen across the country, but it's something that has impacted the whole country. We just published the most recent Intermax database look at what's happening with mechanical circulatory support. And destination therapy has gone from roughly about 45 to 50-ish% of the implants to about 70%. And patients who were listed at the time of implants had gone from sort of the 20-ish, 25-ish% down to less than 10% now. So I think that the world of mechanical circulatory support is evolving towards one of destination therapy, and the world of transplant is moving towards one of more utilization of temporary mechanical circulatory support, and to a lesser degree ECMO, to get patients transplanted without requiring permanent mechanical circulatory support.
Yeah.
Now it's still a little bit in the early stages, so that may shake out a little bit differently over time, but I think certainly within the next couple of years, I think those trends will probably hold.
Talk to us a little bit about your vision for heart transplant and heart failure at Stanford.
Yeah, I mean, I think that maybe I can kind of start from the transplant and work our way backwards. So, I think that we've had, been involved for a long time. I think we had the good fortune of working with very productive and aggressive surgeons as well, that have allowed us to have good volumes here and actually increase our volume somewhat, do things like multi-organ transplantation, heart lungs, heart livers, heart kidneys, sometimes a little bit of all three or four of those things, depending on the candidates. And from a research perspective, I think two of the big things that we've been involved with here at Stanford are Kieran Cush's work on donor allocation and donor acceptance, and sort of looking at what makes a good donor, what makes a bad donor, how can we better match donors to patients, but maybe how we can also better utilize donors. Along with that, we will be starting up our DCD program, and hopefully in the not too distant future, we started using the quote unquote heart in a box, the ex vivo perfusion system to get organs, and that will also allow us to go further afield than we're currently going. And the last sort of thing in transplant is the change to non-invasive graft surveillance first with gene expression profiling, which has been around for a while, but now with cell-free DNA.
Both largely invented here, I think.
Yeah, largely pioneered here for both of those. And, we started going to cell-free DNA after our first biopsy, which is typically at 2 weeks. So within the first month, we switched over to non-invasive surveillance for most people. There's some people who we still do biopsies on, but we've substantially reduced our reliance on biopsies. From mechanical circulatory supports, we're doing more of our implants via thoracotomy. Like I said, it's moving more towards destination therapy, but we'll be part of some trials of less intensive anticoagulation with the HeartMate 3, and some other sort of nifty things coming down the pike that I'm not sure I'm at liberty to say just yet.
That's okay.
But there's also been a focus on RV function. That's been sort of a long-standing interest of mine, sort of understanding RV function pre-implant and predicting post-implant RV dysfunction. And our main VAD surgeon, Will Hiesinger, has also been very involved in that and looking at novel ways in the lab to automate the assessment of right ventricular function and see if that's a better predictor of post-operative RV dysfunction. On the heart failure side, we cover kind of soup to nuts in our heart failure group. We have people like you and Ashley who are looking at people who don't have heart failure or don't have LV dysfunction, but have genetic predispositions to having it, to people who need mechanical circulatory support, and a hypertrophic myopathy clinic and an amyloid clinic, and kind of everything in between. So we're very busy and do a lot of interesting trials. Some of our more recent stuff that we're doing, like I said, is more technology-based, looking at patient activity and tracking patient invasive hemodynamics and seeing if we can reduce readmissions using those new technologies.
Talk about the role that the general fellows play in your clinics and in your clinical work.
Yeah, I mean, I think that we're always encouraging general fellows to become involved. We're always trying to turn people over to the heart failure side of things because obviously it's the most interesting thing you can do in cardiology. But I think that we welcome the general fellows in any kind of part of what we do. We've started to integrate, thanks to your help, general fellows more into the heart failure clinical operations. So on the inpatient side, we have a heart failure and CCU rotation that the fellows have always been an integral part of. There's a VAD and transplant service that the fellows can become a part of and rotate with us. And then on the outpatient side, from any and all of our clinics, the fellows can join. From the genetic myopathy clinics to the hypertrophic clinics to Ron Metellus' amyloid clinic to just general heart failure clinics or even VAD or transplant clinics. So I think we are open to people who are interested. If people want to have experiences and they're not sure, seeing a bunch of outpatients is a good way to get a sense of sort of what the field is like.
It's a busy program, advanced heart failure. I think, you undersold a little bit by saying the volumes have been good. I think the volumes have been quite good and increasing. Maybe tell us a little bit about what they might expect as an advanced heart failure fellow here.
Yeah, so we do sort of 60 to 70 transplants, probably closer to 70 this year. That includes the multi-organs. It doesn't include the heart lungs. We do another maybe 8-ish heart lungs. We do about 1 out of every 3 heart lungs in the U.S. Now, granted, there aren't many heart lung transplants done in the U.S. every year, but we do the bulk of them. We work very closely with the Kaiser Santa Clara group. We do all of sort of Northern California Kaiser. We do all their transplants. Southern California Kaisers go to Cedars. Yeah. So we work very closely with them as part of our day-to-day interactions, and actually as part of the Heart Failure Fellowship as well. We maintain a relatively busy VAD program, and on an inpatient side, the heart failure service is growing, and the CCU services also being quite busy, and we're seeing more and more cardiogenic shock and more temporary mechanical circulatory support. And I think that's a trend that everybody's seeing across the country.
Maybe talk a couple of minutes about the advantages that you've seen from the new hospital.
Yeah, so I mean, I think the new hospital, one, gives us a little bit more just space in general in terms of getting people in. It gives us access to more ORs and more procedure rooms and more ICU beds, which is always good because we tend to be a subspecialty that relies very heavily on the inpatient use of services, particularly critical care services. It's also allowed us to kind of co-locate our patients a little bit better than they had been. The other hospital was more horizontally oriented, and this is more vertically oriented. So we don't have to quite walk as far to see our patients. So it allows us to have all of our CT/ICU patients on one floor, and our CCUs all in one area, and then our kind of recovery floors are all in one space and kind of one column of the hospital. So I think it helps us kind of focus our efforts and allow us to see people a little bit more efficiently as well. But, you know, it's also a beautiful new hospital. The rooms are bigger, the technology is better. You know, even in the era of COVID, when patients maybe can't have as many visitors as once, they can do video visits through their iPads in the rooms and through their TVs, and the views are spectacular, and it's just a much nicer facility.
Now, despite all the hats that you wear at Stanford, you also play an important national, international role. I think you were president of the ISHLT a little bit. Talk a little bit about that experience and how that helps you mentor the fellows, both the general fellows and the advanced heart failure fellows.
I mean, I think the great thing about the ISHLT is that it's interdisciplinary. So it really reflects what we do from day to day. It's not just physicians. It's not just physicians and surgeons. It's ID doctors and pulmonologists and pharmacists. And so it kind of covers the gamut in terms of both clinical care and research. That's one of the things that kind of drew me to the ISHLT. And the other great thing about it is its international nature. So the international nature of the society has always been very important and kind of a core value to the society. And I think that we learn a lot from our colleagues in different countries. I mean, the health systems sometimes are different, so things don't always necessarily translate. But I think that with advanced heart failure, it's also something we can help drive to improve advanced heart failure care in parts of the world where maybe transplant and VAD haven't been taken up as much, and champion those areas of the world as they adopt these technologies and adopt these techniques. And I think India is one of those places where transplant is really starting to take off, and they're starting to develop their national societies, and it's fun to be able to sort of work with their local and national societies to help them to develop and work with them very closely. You know, it's been I kind of grew up in the ISHLT. I started becoming involved mostly through mechanical circulatory support, but a little bit with transplant as well, and was part of the first MCS guidelines and was kind of an early leader of their MCS council, which is sort of an interest group kind of within the ISHLT, and progressed through the board, and then was fortunate enough to be elected president a couple of years ago. I actually got to have my meeting before all the meetings got canceled, so it was nice to actually supervise a meeting in San Diego a couple of years ago. And we're hoping to have our meeting in Toronto next year. I think, fingers crossed, we'll hopefully see people who are interested in April of 2021 in person rather than via video. Yeah. You know, I think that I'm now the immediate past president, which has some roles. The other thing about the ISHLT is it underwent a major reorganization during my presidency. And it wasn't just because I wanted it to; it sort of needed to evolve. It's become a much bigger society. Our CEO was retiring, and we hired a new CEO as part of that process. So I think it was very growthful for me. I learned a lot about strategic planning and working with people and organizing big structures and thinking about how to arrange things and how to sort of implement change. So it's definitely translated into my job here as well.
We get a lot of requests to meet with you. You've mentored a lot of fellows both here and at your previous institution. Talk a little bit about, you know, how you view mentorship and some of the current and exciting projects that you have for fellows that might come here and want to work with you.
Yeah, I mean, I think mentorship is really, really important, and I encourage people to think about, as they're going to an institution, who their mentors might be there. But I think there's also important that mentorship can come from without too. And I'm not saying that there's not enough people here. I think there's lots of people here who do very good work in mentorship. But I think that even where you're coming from, if you keep some of the mentors that you had there, I think having different perspectives is really helpful. But here at Stanford, I mean, I think one of the things that I've kind of been working hard over the course of the past year is revivifying our databases. We started with our transplant database, and I think that does a couple of things. One, it's great for quality projects. It also helps keep a better handle on sort of our data. It can be sometimes difficult to get things out of a typical electronic medical record. Yeah. But I think one of the other really great things in the context of mentoring is it allows access to data for fellows. And so, we have more projects than we know what to do with in terms of the data that we have from both our database and from other research projects that we're doing, and from industry to our own sort of homegrown projects. But I think it allows us to really kind of get people involved and get people interested. I think that it's really important to foster that and the people that have that sort of interest. And I think going through the process of getting the data and analyzing it and writing it up and then standing up in front of people and presenting it, I think is really, really a crucial part of your training in addition to the clinical work that you're doing.
Yeah, I think that's exactly right. And some of these projects are also supported by internal grants like the myocardial biology T32. And I know some of our fellows that are future advanced heart failure fellows that have been maintained on that for several years. Well, yeah, go ahead.
I was going to say, I mean, I think that even if you're not a basic scientist, I mean, I think that there's lots of clinical science. And so whether you're, looking to start your lab one day, or you're more sort of a trialist or an outcomes-based person, which is kind of more of kind of where I grew up, there's just so much to do here and so many people with whom you can work that it makes it a very exciting place to be.
I totally agree. And I have performed interviews with several of your very strong clinical researchers in the division, including our new division chief, Eldrin Lewis, and Ron Watellis, and many others. And Karen Cush, of course. So I hope that the applicants will check it out. Well, Jeff, thank you for talking to me today. Is there anything else that you want to add before we conclude?
No, just best of luck to everybody, and hopefully that if you're coming through Stanford, we'll be able to see you in person. But even if we can't, we look forward to trying to make your visit and your assessment of Stanford as best as we possibly can.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.